Hello everyone, and welcome to the breakout session of Hodgkin Lymphoma. My name is Jumana, the manager of fund development at Lymphoma Canada. I'm pleased to welcome today our expert speaker, Dr. Shruthi Kodad, to answer your questions from the breakout session on Hodgkin Lymphoma. So as a reminder to our audience member, please type your question into the Q&A box in the middle of the black toolbar at the bottom of your screen. We will try to answer as many questions as possible. So I'll start with the first question that we have received. The first question is, what are the different ways of biopsy can be performed? Is one method better or have more conclusive results than another? Is this the only way to confirm of Hodgkin lymphoma diagnosis?
Thank you for that question, and thank you for giving me this opportunity to be a part of this this conference. That's an excellent question. The standard what we follow of diagnosis, especially in Hodgkin's lymphoma, is to try and take out a lymph node in its entirety whenever possible. Sometimes we are unable to do it, especially in case it's not a superficial lymph node, it's very close to the blood vessels, or if it is too big. For example, some people or some patients may have a very big mediastinal or a chest lymph node. In that case, just a piece of a core biopsy should be, enough. At times, we do have to use more than one biopsies in case if we are having trouble finding the right kind of cells and we are having trouble with diagnosis. And then sometimes, yes, we do take like at least one or two lymph nodes out. If it is in the same session, we can do it. But the best case scenario, ideal case scenario, is to get the one lymph node in its entirety and send it for testing. And in some, there is also another method where just a needle aspiration is done. It is good for other kind of cancers like breast cancer or thyroid cancers, not necessarily in Hodgkin's lymphoma. In Hodgkin's lymphoma, we do not get a very good diagnosis just with that needle aspiration. The other question was, is there any other way Hodgkin's lymphoma could be diagnosed? I want to say that if there is bone marrow involvement, we have, and if there is, not a very easily accessible lymph node, sometimes we have done a bone marrow test and then diagnosed Hodgkin's, but still the gold standard is to get a tissue biopsy from one of the lymph node or a tissue out in its entirety.
Thank you for your answer. I think it's clear and comprehensive. So the other question that I see is like, are there any new therapies being developed for the treatment of Hodgkin lymphoma?
Yes, that is a very good question. We have come a very long way. Since many years, we have been using the same regimen called ABVD. And recent findings have basically shown us that there is this agent, this targeted therapy called brentuximab, and that we are using in combination with 3 more medications, which are a similar component of the ABVD protocol. We use the adriamycin, we use the vinblastine and carbazine. So along with that, we use this brentuximab. So that is a fairly recent treatment, what we have been using in the first line therapy for this Hodgkin's lymphomas. And in Canada, we use it for stage 4 Hodgkin's lymphoma because that's where it showed the best benefit. And with this treatment, and this is in the frontline therapy, and in the relapsed refractory settings, we have used the same medication also in the second line or subsequent lines of treatment. We have used, now this is the era of novel agents. We keep hearing about these monoclonal antibodies or PD-1 checkpoint inhibitors. So we have been using these checkpoint inhibitors called pembrolizumab or another medication called nivolumab. So these are the medications which we are currently using. So coming to talks about, is there something else coming apart from these targeted agents? I think we are, eagerly waiting to see what the chimeric antigen receptor T-cell therapy is going to show us in the Hodgkin's world. There have been other target agents, which I spoke to in my presentation about the targeted agents like camitimumab. It's a mouthful to pronounce it, but that is something which is a novel agent and a targeted therapy, which is expected to have some results, but it's very much in the early stages of treatment. So we have to wait and watch if something new comes up.
Right, good, thank you. So the other question: are there any clinical trial available for Hodgkin lymphoma treatment? So if so, how do I get involved, and does my doctor have to approve this?
That's a good, so I think it kind of is very much center dependent. Right now where I'm working, we do not have a lot of trials available for the Hodgkin's lymphoma as it is. The CAR T-cell therapy, which I'm talking about, there could be some clinical trials available, but it's very in the early stages, and it's probably in the United States. I'm not entirely sure if there's anything in Canada. Nothing open as of now in our center. Having said that, I will have to check back and see if there are any other clinical trials available in other centers. So I'm sorry that I do not have information about those, but I can share my email at the end of this talk, and then I can definitely, you guys can send me a question, and then I'll do my best to find out answers to these.
Thank you so much. So the other question is there any way to accelerate the diagnosis of Hodgkin lymphoma? For many young patients like myself, it takes months before we are even being tested for it. Rather, we are told that it is likely a virus and to wait a few weeks before going to see our general practitioner again. So what do you think of that?
Yes, I understand, the frustration and the delays in diagnosis, which does happen, especially in a system where we are really waiting, and the wait lists are huge to either get to your family doctor, and if you do not have a family doctor, it's even more longer. The best way, what I would say, is to increase awareness amongst patients as well as physicians. We know that Hodgkin lymphoma affects the younger population as well as the older population. So there is this bimodal kind of presentation in this. What I would suggest is having an awareness about what symptoms to look for, and if the lymph node, if somebody has a lymphadenopathy and it is associated with features related to an infection, like a sore throat, or somebody got some vaccination and there was some amount of lymphadenopathy or some lymph node enlargement there, then waiting for a week or two does not hamper care. That's what I can tell. But if the lymph nodes do not, regress, the symptoms continue to worsen. The so-called B symptoms, which we speak about, the weight, significant weight loss, loss of appetite, fevers, just those drenching kind of night sweats. So having awareness about these kind of symptoms, along with that lymph node enlargement, which is just not going away even after getting treated with a course of antibiotics, and thinking that this is because of an infection, I think that's when a more expedited investigation should definitely happen. I know that the very first time somebody presents with just one particular site of lymphadenopathy, our usual response is to first rule out the most common things. So we definitely have to rule out infection because that's the most common cause of a lymph node enlargement. But if it is persistent, then yes, just being your own advocate as well as having awareness amongst physicians to look for Hodgkin's lymphomas in these group of patients, and then being aware of these symptoms can definitely help, expedite those lymph node excisions and the scans, which will help us to find the lymphoma earlier.
Excellent. So the other question, does having these symptoms like I did with weight loss and night sweats means that my Hodgkin lymphoma is harder to treat?
It is definitely more aggressive. That's what I would say. If you look at people who did not have these B symptoms than who had, not necessarily harder to treat, but just that the lymphoma is more aggressive. In the novel agent era, I do think that with these availability of target agents, that there will be, the line will be blurred between what these symptoms causing more, more harder to treat kind of lymphoma. But even with the B symptoms, it can, the standard line of treatment, what we are offering right now, the cure rates are still excellent. So the cure rates, which we talk about, 80% or 88% patients being able to achieve a good complete response and then stay in that response for a very long time. That also includes patients who did have B symptoms. So if there is any reassurance, I think it shouldn't make a huge difference in the care or prognosis.
So is Hodgkin lymphoma curable, or should I anticipate a relapse?
Okay, so it is definitely curable. And there is always a percentage we quote. So we always say 80% of the times we are able to achieve a cure. But there are always 20% of the times where the disease either becomes refractory or just stops working or stops responding to a particular set of treatment. We don't know exactly who will behave as what. There might be some high-risk features, what we can tell, which we can predict that they can be harder to treat. For example, if somebody has a really big bulk of disease, more than 10 centimeter mass, and even after the standard treatment, if the disease did not go away completely, then probably, yes, there is a big chance that that'll come back. So there's always a 20% chance that we do say that there will be, there's a chance of relapse. The chances of relapse is, again, the highest in the first 2 years. And that's why your surveillance is more frequent in those first 2 years. And then as time passes, the chances of relapse keep decreasing. And generally we would deem, we would call a patient is cured of this Hodgkin's lymphoma after 5 to 6 years if the cancer doesn't come back, but we still will continue ongoing surveillance once a year. Just because of that 20% chance that the cancer might come back.
Thank you. So we have a question from a 20-year-old female. She says, I'm a 21-year-old female, recently diagnosed with Hodgkin lymphoma. It is important for me to have children in the future. My doctors are telling me to consider fertility preservation. Will all my treatment render my infertile? In your opinion, is this best done before my chemo regime starts?
Okay, that's a very, very important, that's a very important question, as also a very good question. So this is a very common problem in younger individuals who are having this disease. The chances of infertility depend upon what kind of frontline regimen you are going to receive. With the standard ABVD, which is usually used with most of patients with the first line as a first line therapy, the chances of infertility is less than 10%. Having said that, there is still that small chance of infertility. In case that chemotherapy is combined with a pelvic radiation or pelvic area radiation therapy, then the chances of infertility increases. So it makes sense to do your fertility preservation before your chemotherapy starts. Having said that, sometimes not everybody will have the luxury of waiting to undergo your fertility preservation. Say, for example, the disease is really quickly progressing, or you do need to start chemotherapy the very next week. It's not easy for women to undergo fertility preservation, but what you could do is use some ovarian preservation techniques, like you can consult your local fertility clinic. Your doctors can certainly send a referral, and they can use some progesterone-related injections to kind of preserve those ovarian functions when your chemotherapy cycles are going on, so that your fertility is preserved to some extent. In case of something called as a BIACOP regimen, which is a more aggressive kind of regimen, some centers do prefer that for younger fit patients as a first line of treatment. And if that is the regimen being followed, then yes, the chances of infertility is definitely higher in that condition. And I would say yes, definitely do everything you can to preserve your fertility before you start this chemotherapy. Similar thing if some patients are going for a stem cell transplant for Hodgkin's lymphoma, again, the fertility will get affected. If it did not get affected just with the ABVD, it will get affected with the stem cell transplant. It makes sense to go ahead and do your fertility preservation at that time.
Yeah, thank you. So another question, what are the tests that are done to determine how effective my treatments are, or to determine if I need to have another line of treatment?
Yeah, so normally what we would do is once we start somebody on treatment for Hodgkin's lymphoma, after 2 cycles of chemotherapy, we would do a PET scan, a positron emission tomography. This is slightly different than a CT scan. It definitely has lesser radiation, if that is, of some relief for some of our patients. And it uses a radioactive dye which contains glucose. And they give it through intravenous, and it basically can find out if there is any microscopic evidence of small, cancer focuses here and there. And depending on the PET scan result, then your further treatment in the algorithm, what is the best treatment for you can be determined. For example, if the PET is negative, then you could decide either limiting, depending on the stage of the disease and the PET scan response after 2 cycles, you can decide either going for radiation therapy or just 2 more cycles of, the ABVD regimen, depending upon what stage it is. And it will also predict how it is going to behave later. So at the end of treatment, they'll do another PET scan, and that will also be very predictive of how this cancer is going to behave. So if we basically see that everything's gone and there is no light up in the PET scan, then it's extremely good news. That means you're in complete response. And all you have to do is start your surveillance program. Just do your 3 monthly surveillance for 2 years, and then 6 monthly for the 3rd year, and then annually thereafter.
Yes.
In case we do see a small amount of residual disease, or there is this bright light up in one of these scans, it depends upon in how many areas it is showing. If it is something very localized and limited, we can still get rid of it just by using radiation. If it is not too bright, but it is just like a very mild uptake, we can just wait and watch and see if it just goes away after a month of treatment, because chemotherapy itself can cause inflammation, and that itself can cause these falsely higher values of those mild uptakes in some cases. At times, we do get surprises, and we see that the cancer has gone where it was originally there, and then it has come back in another place. And in that case, we do say that, yes, this is progressive. It can happen. And if it is progressive, then that is kind of a cue to say that, yes, you need your next line of treatment. And then maybe it needs something more stronger than just chemotherapy, like a stem cell transplant.
Yes, thank you. So are lymphic massage okay to have for lymphoma patients?
There is no contraindication to massages. The lymphatic massages, I don't think so there is any contraindication, but in case if you're having like sores, if you're having slightly lower platelet counts, some people are very sensitive, especially if they are getting a more aggressive kind of or second line treatment, which can drop your cell counts. Any deep tissue massages can cause like bruises on the skin. And that is something which you should be aware of. Like if your counts are okay, if you're feeling fine, the massages don't necessarily harm you in any way. But we always guide our patients or kind of advise our patients that don't keep palpating the lymph nodes, because if we keep doing that, we do irritate them, we do cause some inflammation, and any inflammation just causes an enlargement in lymph nodes, and that definitely leads to some unnecessary anxiety. So limit the manipulation, but the massages, the lymphatic massages once in a while, I don't see a contraindication there.
Thank you. So our final question of this session will be, is a decision about treating my lymphoma my choice or my doctor's choice? Is it okay to ask for a second opinion?
It is always, always, always patient's choice. And it is always okay to ask for a second opinion. And there is no restrictions about, or there's no force in any of these situations, because it's your body, it's your life, and it is definitely your choice. What I would suggest is gather as much as information as you can from reliable sources, and then make an informed decision. And if you want to make that decision and involve your loved ones, definitely, I think that is definitely recommended. And having a second opinion is not a bad idea at all. It's always, I would definitely encourage it.
Thank you so much. So to conclude this question and answer session, I would like to thank Dr. Kodad for her efforts and time in participating in today's conference session. We hope those watching today learn something new about their or their loved ones' lymphoma subtypes. Please tune into the closing remarks in the auditorium starting in a few minutes. Thank you so much, everyone. Thank you.
Thank you so much for involving me in this. Thank you.